Recording started.
Our evaluator at Arabella Advisors that I thought would be really relevant for you to hear as you prepare your proposals. I know they were certainly really relevant and meaningful to me as we begin to think about the next phase of our work and how to really build upon what I think is the success of the first year of this initiative, but clearly a lot of opportunities for us to do our work better. And just as a reminder, when we engaged with Julie and her team, we really wanted to create an approach to evaluation that was developmental and would support all of us in kind of advancing adaptive leadership, because this is a new body of work for the foundation, and it seems many of you as well. And so we wanted an approach to evaluation that would support you all in looking at how your collaboratives were functioning and what some of the strengths and opportunities were there. We wanted to help us look at the outcomes and the processes in terms of the learning community and this network that we've been trying to build over the last year, with great support and leadership from Mary and Elizabeth. We want to understand the nexus of the policy conversations, and how we're creating good feedback loops with the policy environment. And then finally, for the foundation, we really want to figure out how we can do a better job in executing, our strategy, which has a lot of components, and really supporting you in the best way that we can through grant making and learning and evaluation work broadly. And so really, we see this as a wonderful learning tool, for everyone that we've engaged in this work. So with that, I'm going to turn it over, see if I get my computer advancing. So quick agenda, obviously the welcome, and I'll kick it to Mary and Elizabeth, and then, we'll go into Julie's presentation and let you all we also wanted to give you all an opportunity to really reflect on the experience of...
There's some technical issues with sound.
Okay. I understand there's some technical issues with sound.
It says the audio on your end is clear. And on the phone.
I can find Rachel.
We're getting some chat.
This is Elizabeth.
Let's hope that, I'm going to turn it to Mary, and let's hope that our technology will hold through the remainder of the webinar. But thanks to everyone, and I'll kick it to Mary.
Okay. Since I'm still not having a visual, I don't want to take too much time. Just to echo everything Rachel said in terms of the how wonderful the learning community has been from our perspective, and how much information we've learned, and how impressed we are with the volume of work you've all accomplished. I really want to give the time now to Julie, and we're going to come back at the end of her presentation. We felt very torn between making sure we allowed enough time for Julie to present everything she's found that can be of value to you now, as well as to allow you each to have a little bit of time at least to share some sort of thoughts and experiences that you've had this last several months in working on your project. So we did set aside a little tiny bit of time to also try to do that as well. So let me just go ahead, Julie, and ask you to go ahead and get us started on your findings.
Sure thing. So thanks, Rachel and Mary. And first I want to start off by saying thank you to all of you in the collaborations and partnerships, and being open with me and speaking with me, as well as tolerating my phone observations, etc. I really appreciate the efforts that everyone made to participate in this evaluation. It's been a real joy and honor to participate in this. The topic area is very important to me in terms of integration of primary care and behavioral health, and also being able to not only be an observer to the development of the collaborations, but also to be able to share the successes and great work that you've been doing, as well as share some opportunities that your group might engage in moving forward. So I'm going to write in. I'm going to talk a little fast because I know we're already starting a bit late, and I know that it's important for us to give you a chance to share your own experiences with this. So the findings that I am presenting here is the combination of the interviews that I conducted with project leads, the observations of groups, review of meeting minutes, agendas, and documents, including grant proposals and interim reports, and needs assessments, as well as during the collaboration survey that you all participated earlier this year, pulling all of those data together to really understand what is happening out in the field. To have some very large takeaways, not just around what's happening, but also what are those successes. So I'm going to jump in, and I invite people to ask questions as we move through, rather than waiting until the very end. I want to make this as interactive as possible. So I think this wouldn't be a surprise for folks, but collaborations, all of you are making progress toward understanding opportunities to integrate primary care and behavioral health. There's not a one group that's stalled in that particular arena, and that's very wonderful. But that we also see functions or groups are functioning quite differently from one another, and I think that that's important. I think one of the opportunities with this funding was to give folks the chance to create collaborations and partnerships that reflect those communities, their values, their approaches, both kind of acknowledging historical partnerships as well as creation of new ones. And we certainly see that in how the groups are functioning, all meeting regularly and have agendas. There's a range of note-taking at meetings, some incredibly detailed and others less. But the range and the quality of those notes are not associated with how functional the group is, nor is it associated with whether there's a professional facilitator heading the group or not. We're on 4, by the way. I'm sorry for those of you who are looking at the PowerPoint on your own. I apologize. But we can move to slide 5. Rachel, are you? Yeah, thanks. So majority of partnerships are acknowledging that their group members are working together, but that they're still getting to know one another in the context of integration. And, you know, I think that this is incredibly important, and we're going to dip into this a little bit more later. You know, there are partners at the table who've known each other for some time, and yet talking about integration and really working on that as a content is making partners have to learn more about one another and almost relearn how to work with one another. And I think that that's an incredibly valuable finding that certainly has implications for your groups moving forward. In some collaborations, we see existing partnerships, and those are the foundation of the work. Those folks tended to move more quickly through the assessment, through the needs assessment, if they, in fact, engaged in that. And we also saw movement toward implementation in some of these partnerships where they were existing before. In other partnerships, they may have used familiar folks and people knew each other at the table, but they deliberately incorporated new representatives in order to bring in organizations that were typically not at the table in the past. And so a good example of that is in several of the partnerships, they've started to incorporate substance abuse predators in the conversation where they were not there in the past. And so they're getting to know these organizations, and they may help to integrate services. We can move to slide 6, Rachel. Again, I wanted to really sure we spent some time on this. Integration is posing a new challenge even for groups where folks are familiar with one another. Integration is not a new topic, and so for me, they're somewhat familiar with it, but this is the first time they've come together and thinking about how they're going to actually implement this new model, or rather somewhat old model, but new in the face of our current environment. This has caused some time to reestablish relationships, learn more about each other's systems, and I think that what's important here to understand, and that shared with the team, is that oftentimes in the past, conversations have been very high level around integration, and because of the work of this group and because of what you're trying to accomplish, many conversations had to take very deep dives into processes and procedures happening at different organizations, because that's, as we know, the devil lies in the details. That's where some of the sticky points are around integration. And that took quite a bit of time. It wasn't wasted time for sure. It was necessary and appropriate, but something that I'm not sure folks could have predicted. Can we move on? What we saw is that in some partnerships, there's a lot of learning going on around what each other is doing, what those organizations are doing, and how they can serve as a critical component to the development of the group as well as to the plans for integration. And it's been taking time for groups to become cohesive and committed with regards to integration. Again, regardless of whether or not they had a partnership in the past, this is taking time. And how to go about integration and how much time that takes should not be underestimated. It is taking folks some bit of time, and again, it's not because progress is not being made, but because it's a complex issue. We can move to slide 8. Question, I thought I heard someone maybe say something. Okay. What we also found is that there's incredible commitment around integration, and that's obvious in all of the work that you were doing together, and that collaborative members really believe that the time is now to work on this issue. And I heard that both in interviews, I saw it in observations, and we also see it very clearly in the collaboration survey data. So earlier this year, we shared collaboration survey data with each of the partnerships, and you got to see what your ratings were among your members. Took a step back on that survey and actually created factor scores for each partnership, and then looked at those factor scores across partnerships. So if you recall, the collaboration survey included 40 items. Those 40 items can be rolled up to 20 factors. And those help to kind of relay some of the findings that we're seeing. What is we looked at the factor scores, and we looked at the highest factor scores and the ones where it was the lowest score. And we found as the highest factor scores with each group was members see collaboration as in their interest. So 7 out of the 10 partnerships rated this as one of the highest scores, and favorable political and social climate in 6 of the partnerships. Again, what this is suggesting to us is that there is great commitment. They see it as important to their organization, and that now is really the time to do this work. Can we move to slide 9? In challenges, we saw a few challenges, and I'd have to say that I was struck by the attitude of each and every partnership, that there were very few challenges as described by folks, and when those challenges were described, they were often couched in the idea that they kind of knew these things were coming, and they were still working very hard to address those challenges. So they were challenges that were not preventing movement, but rather they were bumps in the road that people had to slow down for and get over. Several reported difficulties obtaining data around service utilization, either from the state or even from other providers within their partnerships or within their regions. A few collaborations also identified around data sharing and establishing best practices, and for some, they just pushed forward and developed those themselves, or are in the process of developing those, which again was very striking to me, in that I felt the strength of the collaborations and the strength of all of the brains at the table within each of your groups are helping to push problem solving to get through these challenges that perhaps if it was a single organization trying to handle would really impede progress. Let's move to slide 10. terms of promising approaches, so some of the things that we noticed around leadership and skill around leadership included a leader that had a clear vision about what the group could do, even prior to the grant. And that was, what was great and here is just how much actual prep work went into thinking about and planning for this planning grant for many of you, and I think that should be acknowledged. I think that early work actually helped to really set you up to be successful throughout the year. Having familiarity with organizations and knowing their histories, I think, is also an incredible not only skill but knowledge base to work from. I know that in leaders that understood some of the dynamics within organizations, either positive or negative dynamics, were well poised to handle those dynamics within the collaboration and work more effectively at preventing similar issues that maybe those partners had in the past. Pre-11. So to consider for the future, I identified these using lowest factor scores. So again, to bring the collaboration survey back in, we looked at the factor scores within each partnership and which of those factors came up most often as low scores. Sufficient funds, staff, materials, and time. 6 of the partnerships identify that always in a kind of a low way. And I think we heard over that this collaboration, this type of work takes time, and it takes funds in some respect to get folks at the table, and talk about that at the very end when we talk about recommendations. Multiple layers of participation was another area, but the strength in terms of the factors that were scored low across partnerships was less strong, obviously. Only 4 of the partnerships identified multiple layers, and 4 identified development of clear roles and policy guidelines. It's not a majority of partnerships are suggesting that these are things that they need to work on moving forward, but certainly some agreement there for just under half. And consider including substance abuse providers if you're not already. Is certainly something to think about as you move forward. Certainly in those partnerships that are bringing them on board now are taking a greater holistic point of view and pushing that integration model. I think it is a bit more challenging. I think we would all appreciate that. But as you're thinking about your next steps, that might be a place to spend some time. Move to slide 12. We also asked about experiences with the community and particularly with the webinars. And for the most part, those who were new to the topic of integration, that the webinars were somewhat helpful. So they learned a bit about integration and some related areas. Those who were very knowledgeable or more knowledgeable about integration already really wanted more information about specific models and an opportunity to share findings their own partnerships as well as others. Wanted an opportunity to share challenges as well in a safe place so that the partnerships could work together to help one another. Lastly, the policy-related webinar was generally reported as difficult to follow, and that there was an opportunity to really talk about and understand how those policies related to their communities. So a bit more potentially didactics or discussions about how potential policies or current policies at the state level might affect regions, I think is critical to be thinking about moving forward and certainly be a possible target for the learning community next year. So said, part of this evaluation is also to provide recommendations directly to Blue Shield of California Foundation, given the information that we gathered. First and foremost, we recommend that the foundation really nurture collaborations and give them an opportunity to develop trust and deep partnerships. And I think that happens happens by giving folks ample time and space to do that. What we found is that though you made many successes and progress, there's much more to do to further and strengthen these collaborations to create long-lasting change. Certainly for those who use these funds for planning purposes only, additional funds will be required to put those plans into action, and so we would recommend that the foundation consider multi-funding for grantees as opposed to seeing funds potentially in just for a year to support efforts, and really acknowledge that collaborations take time to become cohesive and functional. Another recommendation is to support collaborations in a similar way moving forward, and that way is to really give grants a lot of way to create a group of diverse stakeholders to meet the group helps to provide focus for these collaborations in a way that gives individual communities the opportunity to do it in the way that makes the most sense to them. Grants as these, I heard this often, is that help to keep partners accountable and help them to keep coming to the table. And when the funding is perceived as flexible and giving communities the ability to develop their own groups consistent with their own community's values and approaches, it leads for more potential long-term outcomes. And so we would again suggest to the foundation that they continue to support grants in this way, giving that level of flexibility to partnerships. We also recommend to continue to provide funds to conduct needs assessments as a tool to create and support collaborations. We saw this exercise as being incredibly helpful to engage organizations in conversations about new topics for them, which is integration. And it's also provided a focus and a way to create a plan to move forward. We recommend the foundation offer greater education around integrated models. There's definitely a desire among you to know more about best or promising practices around integration, and more specifically how it might work in California given some of our policy constraints. We also want to be clear about the inclusion of policy discussions with collaborations. Again, to reiterate, there was some confusion on how policies would affect their own communities, and we and folks wanted more guidance around how to use those emerging policies with the context of their partnerships. And so being clear about that and more maybe deliberate in the conversations, I think would be helpful for grantees. And lastly, we recommend creating more learning opportunities among grantees. Many of you greatly appreciated the in-person grantee retreat, and some acknowledged and appreciated the significant costs associated with it, but thought that it was very beneficial to their own learning about what's working in other communities, so they could take that back with them. Some grantees believe that the learning community webinars could focus more on sharing challenges and using each other to help problem solve issues. So there is a concern that if the foundation was present, grantees may not be as candid as they normally would without that presence. So we recommend consider that and thinking about, offering maybe a safer space or ensuring safety in these conversations as forward. So with that, I'm going to stop and ask if there's any questions or comments, and if not, we can move into a conversation about your experiences. Question? Comment?
Hi, this is Esther. Can you hear me?
Yes.
I just had a comment. I wanted to say I was very grateful for your flexibility in acquiring this information. I know our group is very unique, and the fact that you were willing to sit down with us and collect information in a way that was definitely more relevant to our collaboration was fantastic, and I just wanted to say thank you for that.
Thanks, Esther, for that. I appreciate that. I also want to say, and I did hear this from a few, so, even though the evaluator, I'm evaluated as well. And I do know a couple of folks commented that they were concerned about the collaboration survey in a number of ways. One, that it was taken at a time that really didn't reflect the where collaboration was at. That where you are today is different than where you were back in January, which of course is different than where you might have been in August. And I acknowledge that. We as an evaluation team acknowledge that. Blue Shield acknowledges that. We intend to use that survey over the course of time to see how partnerships are developing. It was not intended to be kind of evaluative in that you were doing well or not well, but we were really trying to understand the progress. So I just want to reiterate that to folks, that it was a tool that we were using to really understand what was happening on the ground. But I welcome any feedback around the evaluation and how you think we should change it to better relay your story.
There isn't any more questions. Maybe we'll go ahead and start in on the sharing from your collaborative.
Go ahead and do that, I think, Elizabeth. I don't know if you can hear me. Okay. Yeah.
Yep. Thank you so much for that overview. I really appreciate it. It was really helpful just to hear the synthesis of all of the collaboratives and the evaluation. So thank you very much.
Thank you.
And speaking of, the feed on the webinars, we always wrestle with how to use the time, and we wanted to make sure that we had a few minutes, even though it's limited, for all of your groups to share as we come to a close of this grant period. At the beginning of this grant period, you all gave a snapshot of your hopes and your goals and histories of working together and what we hope to accomplish in this grant period. So this is sort of the end of that, where we wanted to give you an opportunity just to share briefly on your experiences and what you're feeling good about here at the end. So we'll go ahead and start. We've allotted 5 minutes for each group, which I know is very little, and I have my little timer here just to make sure that we kind of keep to that time so everyone gets the chance to share. So if Hank and Shasta can go first.
Hi, this is Melanie Ridley, and I'm happy to start it off unless Lynn or someone else from the collaborative is on the phone. Okay. So I think in terms of the the Shasta County Healthcare Collaborative, I think some of the successes that we've really seen and feel very pleased with include reaching out to new members. So the Shark Healthcare Collaborative has been in existence for a number of years and has some pretty strong relationships across the delivery system partners, but this really provided an opportunity to go and sit down and meet with some other delivery system partners, including substance use treatment providers in the county. And I think that's really helping to build some connections between the primary care providers, the FQHCs, and those substance use treatment providers in the county. And then, joining the collaborative, joining the committee meetings, sharing what services they offer in the community. And I think that's certainly been a really great success that we've seen. I think the other thing is, there's a lot of expertise within the committee on the policy opportunities, and I think there's been a lot of great discussion around, some of the state level policy movements happening with, health homes or the 1115 waiver, and then how that translates to local or regional level. So there's been a lot of really great discussion at the committee level talking about what those implications, what the implications are for service delivery, how that impacts possibilities for further integrating mental health and addiction services into the primary care delivery system. So I think I saw Marta was on the line. I just wanted to ask you if you wanted to add anything else in terms of Shasta County and what you would consider as some of the key successes that we're seeing. Oh, her audio may not be working. I think for now that was definitely what we wanted to share, and I think there's a lot of excitement building over testing some new strategies for further integrating rural health into the primary care service delivery system. With the new partnerships forming with the substance use providers in the county, there's new conversations starting around co-location or some other possibilities as things take shape. So I think there's a lot more to come, which we're really excited about.
Thank you for sharing, Melanie. It really sounds like there's a lot of really deep discussions and sharing going on in your collaborative. It sounds like one of the significant things that's happened for you all over the last year. Do you have anything that you'd like to share about what's next for you all?
In terms of what's next, we're really looking at some of the FQHCs in the county received federal funding to support behavioral health integration as well. So we're really looking at how do we leverage funding for sustainability of some integration strategies, and also how we look at the policy opportunities that are on the horizon. So how we start to build some capacity for managing really complex patients within the FQHC setting that's aligned with the health home demonstration, that we build that capacity locally, and it's meeting the community needs, and it's the building the capacity and aligning with sort of what's happening in the large system changes happening at the state level. So that's really kind of where our focus is, and we have a couple different strategies that we're looking at in terms of, possibly building some new capacity for substance abuse services within one FQHC setting, establishing a group for co-occurring disorders patients that would provide some additional kind of care coordination and resources and supports to those very complex patients. So we'll be sort of building that as we go. That's kind of what's ahead in the next 12 months.
Yeah, that was a good nutshell. Thank you. I was really painted a picture of the increased capacity, within the four walls and between organizations, and also the interaction between the health home policies and where your county would like to go with that. So thank you. Thank you very much for your time and sharing. Go on to the next group. Slide, so someone else can change
Anita?
Slides. I'm sorry. Alameda, yes, Alameda. Can we hear from Alameda?
So this is Jennifer Martinez. Our collaboration was between our healthcare services agency for our indigent care program, as our behavioral health care services agency for the county, and then Alameda Health Consortium, which represents our community federally qualified health centers. And we're looking really to start off implement in a real way something that was only a policy. We had a policy that had been signed by leadership from various agencies to start sharing data on patients between primary care and specialty mental health to enable better care coordination on behalf of those patients between those providers that are often in their own silos. So in terms of what we're most proud of, I think we are thrilled with the kind of culture change that we have seen happening across our county with this work. Some places that there was a lot of concern and reticence about sharing data. That's really moved to interest in sharing that information, let alone even some enthusiasm in some surprising places. I think some groups we were particularly gearing ourselves up to explain and convince maybe the value and purpose of sharing this data. Those have been some of the places we found most enthusiasm and excitement for getting us to a place where we're sharing information that really benefits patients. So great movement beyond a place sometimes of we can't share that data to a place where we're sharing it, and it's getting between different provider groups and filling in the whole picture of clients' care needs and then really enabling better care. So we're excited about that. In the midst of that, we have a work group we have called every month with representatives from each of our primary federally qualified health centers, working out really the details. I mentioned earlier in the webinar that sometimes the devil's in the details. And there's a lot of work that needs to happen, workflows and the IT components to actually get the data to the right people and on the right person's screen to do the work. We're really thrilled by the level of participation we've had by agencies, even beyond those that were officially a part of this collaboration through this grant, but were partners that were really critical to have on board, and we've been really happy to bring along their participation. In terms of learning, this is not a brand new thing, but we were reminded that organizational culture change takes time and maybe longer than we might have thought. There's some examples we've had. A particular part of our project trying to put in place an agreement around which psychotropic medications should be clearly prescribed in a primary care setting, which ones shouldn't, and then how to handle the gray area in between. And I thought that might be a relatively simple thing to start to do at the beginning of our grant. We thought there might even be some examples that we try to leverage well, and found that we were going to really need to create this on our own. Now, towards the end of the grant, have really come back to a simple agreement like we just described, but it really took a whole kind of round-the-clock process and discussion with lots of different stakeholders that kind of blew that concept up bigger, thinking we might need to incorporate lots of other components to it. Then they were able to bring it back down to something that was manageable, but it was really a process that we needed to have happen, that we needed to engage all those stakeholders in getting ourselves to a place where everyone was comfortable with that kind of an agreement. A key component there is just time. You can't rush those kinds of conversations to get people comfortable with sometimes really new and innovative things that haven't had to put in place before. So time is something that we couldn't rush. Similar examples on workflow changes. Sometimes it just takes longer and more practice to actually put those things in place, be the original concept development of what you want to see change. And in terms of next steps for our collaborative, we are glad about the culture change that has happened, and we're happy about all of the testing we've been able to do with our IT reports that we've been able to develop and share between these providers on their shared patients. But we also see that to really get this have traction across our county, we need to make the IT pieces even easier. That we need to have something that's maybe a little closer to a health information exchange. Right now, we're sharing secure reports that are more in an Excel format, providing data. And I really want providers to consistently collaborate on care for their shared patients. We need something that's even more integrated in their everyday workflows, making it even easier for them to do what we're asking them to do. You know, and HIE it looks really different in different places, and we need something that fits the uniqueness of Alameda County. So we're definitely wanting to plan to figure out what is that right product and workflow and connections between all these different sources of data that can actually make the IT pieces flow even more smoothly than we've been able to take place this year. But along with that, if we're sharing that much more information, then we also really want to take the time to do training around stigma reduction for both primary care providers as well as all the other kinds of front desk and customer service staff that are interacting with our particularly mentally ill patients. The more information that's shared, the more benefits that can potentially come to those clients, but we know that there's also a risk there, and we want to really be careful as we're making data sharing easier, that we're also really caring for the whole of these individuals. So we're looking to maybe do those two areas in tandem. I think so. Thank you, Lita. Any questions there from Blue Shield?
You know, we're actually going to have to move on just in the interest of time. But I'm hoping anybody, you know, the foundation or certainly your colleagues on the phone, if they have questions, they'll follow up with you. It's really exciting to hear, particularly this culture change piece, which, like you said, is definitely the one that takes the time and is much more complex. So it's very, very exciting to hear. Thank you very much.
Thank you.
Let's go ahead on for Redwood City. Who would like to share from there?
Hey, this is Michelle Versace from Redwood Community Health Coalition, and we're a coalition in 4 counties, but we did focus this project on Sonoma and Yolo, and we formed 2 different task forces in each of those counties. Those forces also met combined when topics were relevant to both counties. And so as far as our greatest accomplishment, I think bringing together the stakeholders and in the conversations for direct health information exchange. So we identified steps needed for HIE and had some readiness discussions. The group identified the first step for direct HIE as secure provider-to-provider communication and record sharing. Our learnings, we learned that the complexity of the issues with HIE and confidentiality with data sharing was and so still trying to kind of overcome some of those barriers. Some of our next steps, we're really looking to form a regional transformation and innovation community in 4 county regions. So this would also include Marin and Napa counties, as Yolo and Sonoma, where we've currently been engaged. This community is going to develop the workforce competencies that have been identified as needed to fully integrate with a focus on trauma-informed care approaches. Issues that were identified by the task force groups included lack of psychiatrists in the community, training needs in the areas of effective models, behavioral health integration, workflows, as it's been mentioned by many other groups, to incorporate the warm handoff to behavioral health professional during a primary care visit, and training for primary care providers around effective treatment of consumers' behavioral health issues during a primary care visit. And that includes medication management. And so, to kind of the workforce competencies, also identified kind of operationalizing the integrated behavioral health model as an area that our partners wanted to also focus on. So the basic foundation or building blocks, how to work side by side on an integrated team, how to advertise services, going to allow time for the warm handoff, and staffing models, kind of where we're going to be focusing next.
It's all of your 4 counties working together on the workforce competency issues that you talked about sounds really, really powerful. It have a huge impact on a lot of patients. Thank you much for sharing. Auditions, San Luis Obispo, who's going to be sharing?
Yeah, this is Joel Derringer. I've been hi, good afternoon, everyone. I've been the project director and facilitator of the process for the last year under the auspices of the Transitions Mental Health Association. I think one of the successes, or one of the things, was bringing all the partners together. And we kept it relatively small. These are all stakeholders who have relationships with each other, sometimes bilateral, like with FQHC or, the hospital with the county. But this is the first time everyone came together as a group and sat every month to talk about issues on integrating care. So I think that was really helpful because we had multiple perspectives at the table every time. Another success was sort of the opportunity to both identify what the service delivery levels were, and by doing that, identify what the gaps are. Who's actually, we have a lot of people saying, well, our waiting room is full, which is true. But that doesn't mean that there's another 90 people waiting to get in. So once we started looking at what the population or consumer demand is versus what the service delivery levels were, we could identify quite a few gaps in the system. One of the big successes was getting the county together with our FQHC and jointly applying for a grant to SAMHSA for integrated medical care at the county mental health facilities. So this is sort of the other side of integrating care within FQHCs, was trying to integrate care within county mental health facilities. We'll see how that goes. But if we don't get the grant from SAMHSA, I think just having the two agencies having learned to work through that issue together may result in some forward movement even without additional funding. Some of the learnings that came out of year-long collaboration was learning to trust one another, being able to say things without someone feeling very defensive organizationally about that. We've had some institutional changes as we go along, within different agencies, so trying to work through those. One of the other big learnings is we did a series of focus groups with behavioral health consumers. So we all talk to each other, as service providers or as payors in the system. We really we've never had a lot of consumer input, so we did focus groups, which was very interesting to hear from consumers what they really wanted. And they would like integrated care, but moreover, they would like leaders that actually listen to them. This is, that have some empathy and care for them. So it was a reminder that while we can work on all the policy changes and the data, that there were real people with issues who wanted real support or feeling that they were getting that. In terms of the future, I think what we want to do is continue with the data collection, try and get that down on a more standardized level so we can continue to identify how far, what our successes are in actually increasing service delivery. There was a real need recognized for peer navigators, for people to help consumers through the system. There's a lot of agencies and a lot of services, so we want to work on trying to standard navigation through the system. And the other big one is getting ready for the health homes initiatives. Because all the right players in the room to fully develop, when we see a Section 2703 health home initiatives, and we sort of want an early start on it while also waiting to see what all state and federal guidelines that come down as it gets approved. And that's it for the future.
Thanks, Joel, for sharing. It does sound like some of the really significant accomplishments were around the relationship building, which the hope around the trust, and like you said, the ability even to come together to apply for the big SAMHSA bidirectional grant. Is your stuff, regardless of what the outcome is, just to be able to come to do that. So thanks a lot for sharing.
Okay, thanks.
All right, go.
Hello. Good afternoon to everybody. This is Marty Edelman, the project manager for the Blue Shield project down here in San Diego. As far as what we're most proud of accomplishing, I think we feel most proud of the 2 pilot projects we are doing, focusing on different models of cross-system collaboration. And most specifically, I think the work we've done in the transition visit pilot, where we have from one of the 3 FQHCs going to the specialty mental health programs to visit with clients in an effort to facilitate the transition of the client from the specialty mental health program to the FQHC. That pilot, we focused mostly on the patient/client experience. We really wanted to see how they felt about the process. And I think we're very pleased to see that the process is actually going more smoothly than we expected. It's typically taking 1 transition visit for the clients to be willing to make the move, although we allowed for the possibility of 2. And clients are saying really nice things about the whole transition process. So here's one quote from one of the clients. The client said, "You guys have been really good to me the last 24 years. Thank you." So that's in response to the program they're leaving. And then she went on to say, "You and Catherine have done a great job. I think it was very helpful to get to know Catherine at Gifford for that visit and then get to see her over at Mid-City." So Catherine is the staff from the FQHC who came to the special mental health program to provide that visit. And finally, the client says, "It's nice to know I can come back to Gifford if things get bad." So we just feel really good about how the whole thing's going. There are a few warm and fuzzies from clients, or more than a few from clients like the one I just read, to make us kind of feel like we hit the nail on the head with that one. So that was great. As far as most significant learnings from the past year, I think proven that our pilots are feasible, but I think to ensure their success, it's important for us to make sure that we pick the right partners, not just in terms of organizations, but also in terms of even down to the specific providers we work with. And so we have to be careful who we kind of recruit into the process and make sure we're looking for champions and early adopters who are willing to do work. Also, it's important to be able to be flexible in developing the protocols so we can make sure it kind of fits the needs of our FQHC partners, because it's that our different clients each wanted to do things a bit differently, and so having that flexibility to do it has allowed us to really implement the pilots. As far as what we want to do over the next 12 months, we'd like to take our shared treatment planning pilot and move that from a dyad to a triad by adding a substance abuse or MD partner. And we'd also like to create another shared treatment dyad. As far as our transition pilot goes, we want to merge the existing transition pilot into our MHSA-funded project wherever we can. The transition pilot actually benefits our county as it takes people out of their specialty mental health programs and moves them into our FQHCs. So our county has agreed to work with us to sustain and grow that pilot at additional sites around the county by redirecting current resources they have. So I think a great win in terms of the sustainability of that pilot. And then secondly, we want to develop a new transition visit cohort where the MHSA funding can't be used for us to be able to do that. We want to develop an evaluation plan for the various things we're doing, really aimed at kind of trying to answer the larger question, which is, does the work that we're doing in our pilots really lead to improved healthcare outcomes for our clients? So we're going to try to look at several smaller questions to attempt to answer that larger question. So for the treatment planning and transition pilot, we want to see if having people involved in those particular pilots leads to improvement in access to primary care and to various preventative tests and procedures that people typically get in primary care. So are they getting more annual physicals, more other kinds of preventative tests and screenings that people would typically get if they're involved in our little projects? In terms of evaluating the patient experience, we currently survey people transition project about a week after they move from the special mental health program to the FQHC. And we want to continue to follow up with those patients at 3 months and then again at 6 months to see if they're still doing well with regards to their behavioral health needs and symptoms. So really, are the gains that are continuing to remain stable as they move from special mental health to the FQHC system. And we want to continue to look at the provider experience in our shared treatment planning pilot and specifically see what happens with our providers after adding a substance SUD partner. Finally, related to our work on advocacy and overcoming the barriers to both intra-organizational and cross-system integration. One of the areas that was noted in the Arabella survey that we want to work on is engagement of leadership. So to continue to grow and strengthen our collaborations and ensure there's adequate capacity in primary care settings for people with behavioral issues. I want to begin dialogue with our clinic leadership and use the data from the Langer report to try to help them understand what their customers are saying they want and need regarding behavioral health treatment. We think that'll improve our, kind of our engagement with leadership. And the last piece of that part of the project would be want to develop, want to promote a welcoming environment for the clients that are participating in the transition visit pilot. So we want to conduct some behavioral health awareness and sensitivity trainings for first-line staff at the clinics who are participating in those pilots. So I think I hit all of your questions, and hopefully that does it.
Yeah, thank you, Marty. You hit them all. It was really I appreciate you sharing the team's comments and a lot of focus on the patient's experience and also the piece about the leadership focus, looking at the leadership level too. Sounds like there's a success and interesting going forward. So thank you very much for sharing, and we'll move on.
Thank you.
This is Osman from Merced County Public Health Department.
Hey, thank you.
Hi. So I'll start by answering the questions and then seeing if Kathleen has anything to add to what I've said. The first question about what we're most proud of. Our collection is proud of that mapping that we were able to accomplish last year. We were able to gather some really great data, and through working through that process together, our collaboration built a lot of trust. It was a new group that formed a group from a different coalition, and so that one of the first important steps that needed to take place was to develop trust between the partners, and I think we accomplished that, and we have a cohesive group at this point. As far as the data that we collected, with surpassed expectations, especially in the consumer engagement survey, we were able to capture 488 responses from community consumers, general community residents who may not even be already in the mental health or behavioral health system. And that data will be used in the future, not just for this particular process, but within organizations that help to gather the data that are our partners. Found it very helpful. Second question, one of the most significant learnings from this year, we found through the assessment process that the community is ready to address mental health and behavioral health issues. In partnership, we had on whether or not to include certain questions, whether or not the community would be ready for it. And we were bold and did include those questions on the consumer engagement survey. And we paid off, and the responses, we were able to see that the community is really ready to address these issues. And we normally see that through key informant interviews, that the people who are the decision makers may be ready to address something, but if the rest of the community isn't ready, then it's not time. So I'm excited to capture the momentum that we feel we have going. And in next steps, working on several different projects to integrate systems, including referral mechanisms to better serve clients and patients. And we're starting with a shared release of information and working through that process currently. Do you have anything to add?
Hi, I'm Grassi, also with the Merced project. And I would just elaborate a little bit on the our consortium process. As Katie said, we had a healthcare consortium meeting for a number of years, and they were supportive and gave blessing for this project, which but also sent many of their behavioral health staff and other lead staff that we hadn't worked with before. So it was been informative for us, and a good mix of individuals representing behavioral health as well as primary care as well as the community. I would definitely say, as someone said earlier, that we spent the fall thing. By January we were norming, and now we're storming ahead. We've got a lot of buy-in from our partnership, and I think it was evidenced by our collaborative work for a recent community convening where we had somewhere between 70 and 75 individuals show up to reach to our community capacity assessment results, preliminary results, and give us their best thinking about appropriate needs and next steps for our community. So I feel that, as people have been saying all along, investing the time has been well worthwhile this last year, and we hope to be able to use this momentum on projects going forward.
Kathleen and Katie, thank you so much. Really, really exciting, the numbers you had on the survey, and like you said, the boldness in the questions that you're going to ask and the response that you get. And hope be able to share more about that on the community capacity webinar. It's really exciting. So thank you. All right, let's move on. On our rapid clip.
Hi there. Sorry, talking to our mute button was not as effective as we hoped. Can folks hear me now? Just couldn't hear anyone else. Oh, great. So hi, this is Allison Korfeld and Karen Call. Allison Korfeld, I'm from LA Care Health Plan, and Karen is from our consultant group, the Integrated Behavioral Health Project. So we did a little thinking on our accomplishments, and kind of up with two things. Is strengthening existing relationships, because at our table we have the county major safety net payers and providers. So we work together all the time on a million different things. The health plan is working with the Department of Mental Health to implement the mild to moderate health benefits. The Department of Public Health is coordinating with their contractors and with the Department of Health Services. But even with those existing operational relationships going on, developing them in really large organizations can still be a challenge. But that was good. And the other thing we're really proud of, hold on a second. The other thing we're very proud of is the open-minded planning strategy that we took, trying to really focus on the needs of shared consumers, members, patients, or whatever you want to call them, trying to go backwards from what is needed by individuals rather than where challenges are in systems. And we find that to be helpful to us. It's rare to have an opportunity to ask what the work that we should be doing together instead of just how do we get this new operational challenge or new state mandate done. Those have been two really helpful things during this period. Significant learning. I talked about this, I remember, 7 months ago, but it's still important, is talking about the diversity and similarities across Los Angeles County neighborhoods in terms of the kinds of consumers and patients they have, the different mental health, substance use disorder, and actually homeless service provider resources, very differently distributed, very different cultures across different areas of the county, also very different levels of how much they collaborate with one another in those areas. So really understanding that is that you going in, even though all of the county, some of the county-facing net payers and providers, we're going to need a varied approach. There's not going to be one thing that works in all areas of the county. So really having that reinforced for us is important. So I think I have a much better understanding of the barriers to improved health outcomes for the population we focused on, which is individuals with co-occurring mental health and substance use disorder who are homeless. So, the integrating and coordinating care amongst these different sectors is key. Just the strong connection between health and housing, which so much affects the population, understanding that set of barriers much better to be able to better address what we do about them, as opposed to looking at the barriers in the service side. There are many barriers to service delivery, but what are the barriers from the perspective of the individual? Last, in terms of next steps, really hoping to accomplish next. And still, we have had a lot of progress in understanding our shared vision and goals, what a health neighborhood is or could be. We have a much broad sense that we've developed together, but to get more concrete, how can we turn this shared vision into something that we operationalize in multiple places across our county? Some of the key next steps, agreeing on the specific actions that bring us to that vision. So translating some of the conceptual design and planning to operational planning in our 4 selected neighborhoods. Now, the other big area we're really looking forward to and very excited about, we're going to use the new funding streams and also the new funding flexibilities in Cal 2020 waiver, the Drug Medi-Cal 1115 waiver, the health homes, and then a couple of other statewide opportunities. So that financing piece and what is about to be available is a real area of excitement for us. So those are the 3 things we're looking towards next.
Thank you so much. It's really exciting to hear when you're talking about how massive your collaboration in your county is, to talk about you're working directly to consumers and clients and asking them what kind of work should you be doing. That's very exciting, and your next steps too. So thank you for sharing. So San Bernardino. Sorry.
Hi, can you hear me? Yes. Hello, hi. This is Elizabeth Community Clinic Association of San Bernardino County. So I'll be sharing some of the findings from this year. As far as what we're most proud of, we continue to have support from key leaders in our county, which is great. We have, Department of Health, our county health plan, any of our PCP community clinics, very interested in continuing to advance the work that we're doing this year. And we're very proud that some of our partners have developed and strengthened some cross-system relationships amongst each other, and our partners are now leading very innovative, large-scale behavioral health initiatives across several sectors of our county. So it's great work that we're very excited has been developing over the course of this year. As for learnings for this year, some of our immediate or on learnings, we realized that it was very challenging, the range of partners involved in this collaborative, to agree on a county-wide vision for integrated care. We knew that it was difficult to shift the focus to integrated behavioral health for some of our partners. because of lack of knowledge, what it would take, limitations as far as resources and provider capacity. And as far as our capacity assessment, one of the things that really stood out to us was that there was a limited experience in integrated behavioral health care for primary care clinics in specific. And there was also a severe shortage of behavioral health services for rural parts of our county. So we realized, for community clinics in particular, there's still a lack of understanding on what it takes to do integrated care, not only within a facility but also cross sector. So we also found that we need to increase engagement in our partnership with other providers, staff, managers, the organizations that we partner with in order to make progress. Overall, in order to achieve the system-level changes that can transform cross-sector relationships, it's going to really take time and reach penetration within these various agencies in our county to continue the work that we're doing. But we have been moving forward. Next steps for our collaborative. So one of the things, we did do a capacity assessment I want to share with our county, and I think that's going to really be in college of our population needs and what we need to do to address complex transitions of care for these populations who deal with complex medical and behavioral health needs. So I think that sharing will be a really great opportunity for others in our county to be informed about the work we're doing and how we can work as a collaborative to address that. Our county partners also express interest in tracking kind of what's going on in our county, and we still struggle with sharing information as far as all the work that's being done. And we would like to track any concurrent grants, initiatives, and pilots that can be leveraged to accelerate system change. So we'll continue to keep everyone up to date with the growth going on. In the course of 12 months, what we, based on kind of what we identified from this year and the idea that, we still like to do some more efforts related to transfer. So having clinics in particular have an opportunity to engage in integrative efforts. And the way we thought we could do this is by developing a cohort of clinic teams. So we invited about 6 clinics to participate. And these clinics, have different levels of integration within the facilities, but they'll be engaging in intensive learning, planning, and leadership development related to behavioral health integration. And, some of these clinics may need, some more behavioral health 101, regarding screening and referrals for behavioral health services and measuring clinical progress for patients. So that provided hopefully by our consultants. And then, we anticipate that this will help with system-level change in our county, and it'll begin to unfold when the care providers have the knowledge and resources to be able to, to foster this level cross-sector work. And then the other thing that we would like to do is offer an opportunity to for partners in our county, such as the Department of Behavioral Health, or Health Plan IP, Public Health, to engage in some discussions related to key issues such as addressing, the mental health benefits for the mild to moderate population, improving transitions of care and care coordination using interdisciplinary teams, expert implementation and challenges, medication assistance, treatment for the addiction population. So just key areas that benefit both primary care clinics and then also our partners in the county, and really having an ask for those discussions to take place. We would also like to implement a consumer perspective study on integrated care, which we unfortunately weren't able to do this year, but that's really what we would like to do with our primary care clinics who are involved in this cohort. And we, would obviously embed the discussion of system-level leadership and collective accountability in all of these discussions so that we're taking both hand in hand. And then the other thing that we really would like to accomplish is we really like to have our hospital system and other social service providers involved in these discussions, so we'll be bringing them in to discussions as well. That is all I have. Covered all questions.
Yeah, great. Thank you so much. Thanks for that, focus on foundational issues of the relationships and the capacity and the invite of new partners going forward that seem like they need at the table. So that's great. Thank you so much, Liz. And let's go to you.
Jill Phillips from Siskiyou County. I'm the director of the Siskiyou Community Services Council, the grantee for this project. And also on the phone is Marta McKenzie and Melanie, and so I would like for them to chime in if there's opportunities. I'd like to say, first of all, we're very fortunate in that Marta and Melanie are consultants and also the consultants for Shasta County. So in a way, that's given us the opportunity to really do some regional learning and regional sharing. This has been just exceptional process. Our organization, the Community Services Council, has been doing broader level systems integration work for a long time. That's within our mission. And now working with this project in focusing on the behavioral health aspects brought up a lot of learning opportunities personally and for our organization. I think for the Behavioral Health Task Group, the getting together of the different providers and building momentum. These conversations have happened, but more informally, and now everyone seems to be very much looking forward to the opportunities to learn from each other. I think one of the things that we understood is that there's a lot to learn about what the different organizations were doing. We had an opportunity to map the resources fairly well in the county, and the group decided to expand the look at resources beyond the traditional and look at all of those kinds of supporting things, resources that can be entered into the system and considered as we look at our systems development. Do you have anything to add as far as things that we learned or accomplishments?
This is Melanie, and I'll just echo that. I think in terms of learning who's offering services in the community and where those services are located geographically, I think that really has been a great process for the group and has been interesting to watch it unfold. So I think the way we approached that was a great kind of feedback process within the group and has helped kind of build relationships across partners.
This is Mike. Can you hear me? Yeah. The other learning is, yes, many providers there really are. I think traditionally in counties like Siskiyou, where it's a pretty small population, the county has been seen as the central player. And I think with the emergence of the mild to moderate benefit and really recognition of a whole other set of providers, including 109ers and the school psychologists and other folks, it's really expanded the perspective that there are many more folks who need to be brought into the collaborative to talk about the systems work. So from my point of view, that's been one of the most interesting things in Siskiyou is kind of this really expansion of the worldview about who's really providing behavioral health care.
Yes, I think that as we go forward in looking at our next steps, we're very interested in doing a little more formal mapping of the care pathways. We have a kind of a good sense of who the providers are. We need a little more information about what their capacity is and what the capacity is that they're operating at now. But we really need to, we know there's a lot of informal referral processes going on between those different systems, and we want to get a good sense, and then we want to systemize and formalize those referral pathways. And we are interested in developing a GIS mapping that as the systems are developed, we can include so that everyone has access to what's available where. We are very, very spread out to over 6,400 square miles, so location is critical, and knowing where things are is critical. And then the next thing that we really are interested in working on is part of our learning and our needs assessment. We knew this really, but it was confirmed that we don't have, we really have very few substance use treatment resources. And so that is a whole area that we're interested in developing over the next year, looking at all the potentials for that. And along with that, the policy aspects. You know, there's so much exciting policy work going on, and we want to be ready to take advantage of any opportunities that come along to develop our systems. And after that, we're very interested in initiating a small pilot project that really looks at integrating resources for shared populations. So as Marta had talked about earlier, we know that there's service being provided with criminal justice realignment dollars, with MHSA dollars, with other community resources, and we want to align those with our primary care, our FQH, our tribal resources, and our county resources, and show what a system can look like in a rural community.
Thank you, Jill. Thank you. This guy you're sharing, and we're right up against our time, so let's go right on in for Kukui.
Hey everyone, yes. Hi, can you hear me?
Yep.
Yes.
Okay, great. Hi everyone. I know that I'm going for a reason because I'm slightly different than everybody else, but I have to tell you, our collaborative is pretty proud of something, because we know that when we are part of a planning process, sometimes you just have to be aware of the windows of opportunity and take them as they come. And we had an incredible success with the Drug Medi-Cal Organized Delivery System waiver amendment. And that is that we successfully advocated with Karen Baylor to have a separate Indian organized delivery system, drug med delivery system.
Wow.
Yeah, we just got, we're just notified of that on May 11th. And if I could just take a moment to kind of walk everyone through that process. Especially when they were offering drug Medi-Cal expansion, we recognized that it was about strengthening county systems, which is absolutely a valuable contribution. We also recognized that there were no Indian health programs funded through the drug Medi-Cal system, and there were various reasons for that. So when we met with Karen Baylor initially, you know, her response was, wow, I don't know anything American Indians and you know, not urban Indians. And so we had to start from very, you know, ground level. Educating her office, we also had to map out our separate Indian Health Service organized delivery system and demonstrate how that actually fit into the ASAM criteria. What was interesting about that, which is a really strong learning point from this year, was to be able to demonstrate in kind of like this Western model how our it's basically a holistic system of care functions. Because certainly we've always functioned with our substance use providers and our FQHCs and behavioral health providers, but to be able to map it out and demonstrate exactly which providers functioned in what role was very, very useful. Initially, we were told that we would have to wait until the waiver amendment was approved and we would have to submit a separate Indian amendment. But now it looks like we're going to be part of the Phase 5 rollout for the current waiver amendment. So within 6 months to a year, we should be able to see some changes. Now, that is very important to us because they're actually components of the Drug Medi-Cal reimbursement system that leave room for reimbursement for traditional healing practices. And and care coordinators, or in our communities we like to call natural helpers, that would also be significant. So we still have to map out how it is going to be administered and monitored, but at this point we're very excited. And we did this in collaboration with Indian Health Service Area Office, and also what used to be Indian health programs at the state level, and certainly with our information provided with through our collaborative. I think that those are all of the reasons that this was successful. So we're very hopeful for the upcoming year. I think I shared a little bit of our most significant learnings, and to me maybe this is a surprise because I feel like this work has been done for a long period of time, certainly over 30 years, and to find that still at the systems level, we have so much educating to do in American Indian people and urban Indian people specifically. So, that helps us really build that into our policy advocacy change strategy and efforts. And our next steps, we have a couple of things. So we would like to continue to monitor the implementation of our integrated, culturally relevant integrated behavioral health model within our urban Indian clinics to identify both successes and barriers and, certainly adapt accordingly. And we would also like to continue our advocacy. I mean, right now, we all know that it's a really hot time for transitions in behavioral health. So obviously 2703 is going to be significant advocacy for us, and certainly use the precedent set through, this recent success to create change. So yes, those updates.
I'm sorry you got squished again, and thank you so much for packing a lot into a few minutes. I really appreciate it.
No problem. No problem.
The policy advocacy stuff that you're doing. And I know it's 1:32 right now. Rachel or Mary, would you like to say anything the last few seconds?
Rachel, I just want to say it's just amazing and awesome listening to all the work that's gone on in this month period, which we know from Julie is a very short amount of time, really, to do the level of engagement, community engagement, relationship building, and systems development. But I feel like there's just been, rich learning and, collaboration that's gone on through the grants, which was really what we hoped for at the start of this process. And so I'm really in an active thinking mode right now in thinking about next steps. And so I'm really listening to the areas that folks want to focus on moving forward. And I'm really trying to think about how to best structure our learning community engagement work accordingly. And so I'm hoping you've all been so good at responding to us so far, but we'd like to issue a survey that would help us go a little deeper with you all in terms of how we could really structure the learning component moving forward, and I think the policy component as well. The Making for Better or for Worse will kind of look like it will, because that's already in motion until thinking ahead to 2016. We'd really love your partnership and your input. And so Julie, I think, will be sending out a survey in the next month or so that will help us really design, next level of work. And so I think for me, there's a combination of really understanding some of the best practices around the art of collaboration, which you all are learning about in real time. And then, of course, there's really practices around integration. How do we support you in some of the innovations that you've shared on the call? And then, of course, policy work, which I know, a lot of you have mentioned, which is hopeful for me, but how do we continue to really, hone, this relationship between your local work and the state work in creating that feedback loop. So I'll stop rambling, but really want your input, and hopefully we'll get additional input and feedback from you in the next month or so, and I really look forward to reading all the proposals.
And Mary, I don't know if you can hear me, but I too just want to echo that it's really quite stunning to hear the progress and the wonderful work that you've achieved, and it's really gratifying to hear your hard work, and it's really great. And also to just encourage you to support the work that Rachel just mentioned, because I think to make the learning community and policy work even stronger would be really great. And then also I just want to put a plug in. We did say out a notice, I don't know if we have a slide that says next meetings, but we were so impressed by the work that came back from the community capacity assessment work that you all did. And for anybody who's thinking about going in that direction, and for all of you that have already done it and have more information to share, we really felt like we couldn't close out the year without sharing that. So we did take the liberty of scheduling a real final learning community call on July 8th to really delve into that, because the work was so compelling. So we'll be sending you more information about that. And we have up here the due date for the RFPs, but of course you know that. So thanks, everybody. That.
Thank you, everybody.
Take care, everybody.
Bye.
Thank you.
Thank you.
Thank you.